In the education of healthcare professionals such as medics, dentists, and nurses, communication is one of the main taught and assessed skill areas across programmes. However, the feedback that students receive on this is usually given from one professional perspective, and usually the professional perspective that they themselves are being trained in. Within the dental school, we could see some of the issues with this model, and we decided to try and incorporate feedback to students from other professional perspectives in order to allow students to learn in a more collaborative way and in a way that was more akin to what clinic is like. Communication skills are vital for any healthcare practitioner. However, the teaching of communication skills remains largely mono-professional across the different disciplines. Students typically learn and receive feedback from somebody who has been educated within the same clinical and professional framework that they themselves have been educated in. Whilst this can be useful to develop profession-specific skills, it can also result in communication norms within a profession that mean that it can be difficult to communicate between professions and possibly also to members of the public. Within this traditional framework, students are only exposed to one clinical lens, where problems and solutions are only seen through one paradigm. However, we know that real healthcare delivery is interprofessional. Healthcare is delivered in multidisciplinary teams with different individuals from different professional backgrounds coming together to communicate and to work with a patient in order to improve the patient's health. Within the dental school, we decided to address this problem by giving our undergraduate dental students the opportunity to receive feedback from other healthcare professions. This project drew upon three educational principles, the first of which is authentic assessment, ensuring that the learning tasks that we give our students reflect real professional environments and real situations that they are likely to experience once they're qualified. The second principle is dialogic feedback. We know that feedback is most powerful and is most useful to students when it's delivered as part of a conversation, and that conversation includes multiple perspectives. The third principle is professional identity formation. We wanted to make sure that our students were exposed to other professions they wouldn't necessarily be given the chance to in normal educational practice. We knew that this was important because such exposure will help our students to understand how they practice and not just the technical skills of what they do. In order to appropriately conceptualise this project, we developed the embedded professional feedback model, which informed how we structured the project and how we created an environment whereby dental undergraduates were given appropriate feedback from other professional colleagues. This project involved various healthcare training programmes. Second-year undergraduate dental and hygiene students were invited to a communication training exercise where they conducted simulated patient consultations with trained actors. These simulated conversations were observed by various other individuals, including second-year clinical psychology trainees. These trainees were asked to provide feedback to the oral health students on their communication. We chose clinical psychology trainees because they bring a particularly strong lens on interpersonal processes, empathy, and relational dynamics within consultations. Dental students already receive feedback on clinical content and structure, but psychology trainees can notice things slightly differently. For example, how emotions are responded to, how rapport is built, and how the interaction may be experienced by the patient. That made their perspective both complementary and educationally valuable. In addition to the clinical psychology students, feedback came from multiple other sources as well by peer undergraduate dental students who were also involved in the exercise. The actor and the faculty member as well were also involved in giving student feedback, and the faculty was involved in guiding the whole process. This resulted in a structured reflective dialogue between all participants after the simulated consultation with the actor. What does this model add to learning and teaching practice? First, it functions as a form of cognitive apprenticeship drawn on the work by Collins, Brown, and Newman. In traditional communication teaching, students often receive feedback in quite evaluative terms. What was done well and what could be improved. What happens here is slightly different. Students are exposed to the reasoning process of practitioners, some experienced, some students, as they analyse the interaction. They hear how professionals interpret cues, identify relational dynamics, and prioritise different aspects of the conversation. In other words, the internal thinking about communication becomes visible. Second, the model develops feedback literacy, which is increasingly recognised as an important graduate capability in higher education. Rather than just passively receiving feedback from a single authority figure, learners encounter multiple professional perspectives. They have to interpret, compare, and decide how to apply that feedback, which mirrors how professional learning actually happens in clinical environments. Third, it introduces a greater psychological depth into communication teaching. Much communication training, understandably, focuses on observable behaviours, asking open questions, structuring explanations, introducing yourself to the patient, and so on. What this model encourages is a deeper analysis of the interaction, the emotional signals present in the conversation, the patient's meaning making, and the relational process that actually shapes the exchange. Fourth, the design provides meaningful interprofessional exposure. Students encounter how different professions attend to different elements of the same interaction, whether that's clinical clarity, whether it's emotional containment, or behavioural motivation, and so forth. This helps students appreciate that communication in healthcare is inherently team-based and involves multiple perspectives. Taken together, this approach does pedagogically shift communication learning away from communication as a performance within an assessment and towards communication as a developing professional capacity, one that emerges through dialogue, reflection, and exposure to diverse professional ways of seeing the same patient encounter. So, what did we actually observe when this model was implemented? Across cohorts, one of the clearest changes was that feedback became much more concrete. Rather than general comments like that went well or maybe ask more open questions, students started pointing to very specific moments in the interaction, identifying how a particular question shaped the patient's responses or how a small shift in wording changed a tone of the conversation. We also saw a deeper level of student reflection. When students were exposed to multiple professional perspectives, it seemed to prompt more thoughtful consideration of their own communication style and the assumptions that they were bringing to the interaction. A third change was that we saw greater attention to empathy and relational dynamics between the patient and the healthcare professional. Feedback discussions moved beyond whether simply information had been delivered clearly and towards how the patient was experiencing the interaction, how emotions were acknowledged, how trust was built, and how meaning was negotiated within the conversation itself. Another interesting outcome was the development of confidence among psychology trainees in teaching and evaluative roles. Because they were contributing to feedback discussions alongside other disciplines, they began to see themselves not just as learners, but as emerging educators and clinical thinkers as well. We also saw strong engagement across the disciplines. Students seemed genuinely interested in hearing how other professions interpreted the same interaction, and this often generated quite rich and deep discussions. Perhaps the most notable point is that these learning gains were achieved without major curriculum redesign or additional resources. The intervention itself is quite small structurally, but it appears to produce meaningful educational benefits simply by introducing intentional interprofessionalism into the existing teaching activity.
So, what does this approach add to learning and teaching practice? First, it provides a replicable micro-interprofessional model. Rather than requiring major curriculum restructuring, the design is embedded within the existing teaching. That means programs can introduce meaningful interprofessional learning without creating entirely new modules. Second, students develop dual employability capabilities. They're not only practicing communication with patients, but also learning how to give and interpret professional feedback, something that is essential in real healthcare teams. Third, it offers a cost-efficient route to authentic assessment. We're not building expensive simulations or additional teaching structures, but we're simply bringing different professional perspectives into the same learning activity. And finally, it strengthens students' appreciation of team-based healthcare practice because they begin to see how different professions interpret the same interaction. So the key message is, interprofessional learning doesn't necessarily require structural overhaul. Often it simply requires new intentional educational design. I'll finish with a simple observation. Healthcare students are very rarely observed through another profession's psychological or relational lens during their training, yet their patients experience them that way every day. If we want healthcare graduates who are genuinely capable of person-centered care, then communication training itself needs to reflect the reality of healthcare practice. And that means making communication learning interprofessional.